Hello, my name is Oluchi Ihionu, and I'm a fourth-year medical student here at BU, and it is my pleasure to talk to you about my research project titled Demographic Factors Associated with Differential Access to Treatment in Keratoconus Patients at a U.S. Urban Safety Net Hospital. Keratoconus is a type of corneal ectasia that is characterized by bulging and thinning of the cornea. It often results in myopia or nearsightedness and irregular astigmatism, resulting in decreased visual acuity. The prevalence in the United States is about 1 in 2,000, and current standards of care include non-surgical treatment, such as rigid gas permeable lenses or scleral lenses, and surgical interventions such as corneal cross-linking, the focus in our study, intrastromal ring segments, corneal grafting, or photorefractive keratectomy. In severe cases of keratoconus, corneal transplant may be utilized. Currently, there is limited information regarding the potential influence of demographic factors on keratoconus outcomes. In our study, we wanted to explore how social determinants of health affected patients with keratoconus and their access to treatment. Social determinants of health are the non-medical factors, such as demographic factors, that influence health outcomes. The demographic factors of interest in this study were race, ethnicity, insurance status, area deprivation index or ADI, and patient preferred language. Area deprivation index or ADI allows for rankings of neighborhoods by socioeconomic disadvantage in a region of interest, either at the state or national level. We examined electronic medical records of keratoconus patients at Boston Medical Center from 2012 to 2020 in order to obtain cross-linking and contact lens treatment records, race, ethnicity, primary language, insurance status, and home address for ADI classification. 32 of 572 patients were excluded due to the lack of complete clinical notes. National ADI quintile was determined by address, and patients were categorized into first, second, or third quintiles and above, third indicating the most disadvantaged. Logistic regression models were used to calculate odds ratios for keratoconus treatment adjusted for age, ADI, insurance status, race, ethnicity, and language. We found that there was no significant association between ADI and cross-linking treatment or contact lens access. Insurance status and race and ethnicity had significant associations with cross-linking treatment in multivariate models. Patients whose primary language was not English were less likely to have contact lens access relative to patients whose primary language was English. Additionally, white patients were more likely to receive cross-linking relative to Black patients when adjusted for all other factors, including insurance status. Also, white patients were more likely to receive cross-linking relative to patients whose race was categorized as other or unknown. We found that race, ethnicity, primary language, and insurance status were significantly associated with access to keratoconus treatment in our sample. Area deprivation index was not associated with contact lens access or cross-linking treatment. These results open an area for further research that investigates the relationship between demographic factors and keratoconus treatment. Further study to determine the reasons for such disparities and how to make keratoconus treatment accessible and more equitable is warranted. There are a few limitations in our study. First, our sample size was quite small, which could affect the generalizability of the study. And second, severity of presentation was not determined at this time, as cross-linking is only available for patients with non-severe disease. Thank you for the opportunity for me to present my research, and I look forward to answering questions at the symposium next month.